Don't dig in too much. If you're digging in too much, your tip is just going right in.
Okay.
Be more precise. I hope this is not tumor. Really bad if this is positive. You taking over just for a second?
Sure.
You know what a good surgeon is? Early in the training, when you look at the residents, you can tell if that resident is good. It's just natural how they do the dissection and how they move the instruments. But if they don't try to improve their skills, they stop there.
So before you come in, let's line this up. See the direction. Pull back a little bit, Lucius. Okay, and then come more distal. That's close to the tumor, just be careful.
It's because of the researchers in the past that we are here now.
Stop. What's happening? What's happening?
If we do not do research, we're going to continue to do the same thing over and over.
I have a feeling you might have to open. I mean, conversion is not a failure, so.
No, exactly, right, like,
Do you agree?
I agree, yeah.
Yes, you agree?
Tomorrow, August 1st, World Lung Cancer Day, which is dedicated to raising awareness about the deadly disease. Lung cancer is the leading cause of cancer deaths globally, claiming the lives of close to 21,000 Canadians each year. So here to debunk some lung cancer.
Well, so this is what happens, like, right where streetcar garbage truck is like the worst combination on the road because neither can pass each other. I've been researching in thoracic surgery now for close to 10 years. And in that time, there's been a lot of really interesting projects, but it is truly only a handful that really get close to the bedside. People will spend their entire careers to have one significant win. It's such a testament to Toronto that we've got teams that can do this not only once, but multiple times. So Kazu is truly someone that really, kind of led and reshaped the field. He led the development of the EBUS TBNA needle, and this procedure is something that's used all around the world.
Usually EBUS is used to biopsy the lymph nodes around the airway.
And then those samples are collected and then sent for pathology for downstream analysis.
To ensure that we have good samples during the procedure, rapid on-site cytology, or ROSE, is where a cytopathologist comes and looks at what do you have. Is it cancer cells that you're getting?
The caveat is having that expert in the room doesn't happen all the time. Many procedures are performed without ROSE, which ultimately relates to delay in treatment.
For patients with cancer, time is ticking. We want to prevent delays as much as possible. And that's why I came up with an idea that if there is a rapid diagnostic device where it'll tell you if you're getting an adequate sample or not, that would
kind of fundamentally change the way in which we treat and how we assess lung cancer patients.
It's taken us about 15 years to come up with this world's first prototype. What I'm hoping is that we would do first in-patient testing by the end of 2024 And if that goes well, then there's a potential of becoming, approved for use in patients.
Our goal is to use this device in clinical setting. So theoretically, it works, but before using a human sample, we need to validate its performance. I think we need to repeat this experiment using more samples. I tested this chip using two different solutions. One is saline and another is PBSD. With saline, it didn't show a good result, but PBSD works well. But the big problem is we don't know how PBSD affects the sample quality. So I'm not sure if, say, the pathologist will accept this PBSD used in clinical setting. So I think it's a huge problem. This is a research, not going straightforward, not easy.
Can I bring you up then? Can I bring you upstairs? Can you say goodnight?
Good night, Lowie.
There's a knack and, of really having a clear way of presenting your research. And I think you get so immersed in your field that you're like, oh yeah, you throw around acronyms and you try to explain it. And it's the same whenever I talk to my family. It's like, how is science, right? It's a non-starter if it's too slow. When we developed the ROSE HD test, we couldn't come back and say, oh, it's a 10-minute test, it's a 20-minute test. Like, there's just no way that could ever work in this clinical setting. In talking with Tsukasa, I think it's become quite clear that we can achieve that really quick testing time of 3 minutes if we use a solution like PBST. The issue was, well, if it was in PBST and that just changed how the cells looked, the pathology review of it could be different. And I think that's something that we can test on our end by working with pathology to confirm that this approach will also work for their downstream testing in the pathology lab.
And today is what, Friday?
It is Friday.
Yeah, I don't believe it, but yeah.
It's funny, today's pizza day at our kids' school, so the happiest they'll ever wake up when it's pizza day. He's like, hey, he's like, it's pizza day.
So I learned that today is the week and function of pizza day.
Exactly.
I love it.
Yeah.
Positive association with Friday.
Just refresh my memory. Approximately, even here, how many cases do we have, Rose?
So half. So Kazu has 8 cases a day, and 4 cases with Rose, and 4 cases without Rose.
In terms of the speed, I think when Rose is there and they're giving that readout for sample adequacy, they can do it within 3 minutes. So therefore, if you get it wrong, it's going to be, a completely disruptive test, and then no one would use it, right? So we have to get that part right.
I think you're right there, right? Because ultimately we want to do what? We want to show the proof of principle and get rid of the pain points. Because the pain points is where I think we'll have trouble convincing the application of it.
Okay, so we need to set up the meeting with Kazu and pathology. I think what we really need in that meeting is the okay from pathology to put 1 ml of PBST into the 50 mL of Cytolite. And then we're off to the races after that.
Okay, I will try some additional tests, and also adding more specimens or some tissues are available. I can do investigating on that but
Pig lung.
yeah, big.
Okay. We may have one.
It's not a big one.
No, I think this was
Very small.
22.
Kilo? Oh, very small. Oh, very small trachea. Very small. Is it penetrate? No, right?
No.
Okay, good. Okay, can I have the back lock? Thank you. Oh, some juice. Okay, could you hold the scope? Okay, first I will dip the tip of the needle in the solution. Some splash I could see around here. So next, this one. So okay. Good. No leaking at all. But I don't know if they are happy with this small amount of suspension liquid, 1 ml.
Just
Like
because
imagine
there's more in it.
mistakenly,
Yeah.
you know, open this one and someone is
It'd be terrible.
That's for terrible.
They lose everything.
Yeah, lose everything.
Sorry, Kazu.
No, we can't say that. Hi.
Hi.
Thank you for the time.
Oh yeah.
Are you on call?
I'm on call. Yeah.
Oh, sorry.
call for
Should be quick.
Yeah. I have a I'm working on a donor right now. So.
Oh, okay. Yeah, I'd like to discuss the next step of the Rhodes HD clinical validation study.
The problem is this marker is going to read insufficient, but we don't know,
You don't know. Yeah.
right? We don't know if the actual final cytology is insufficient.
I don't get it. So,
This specimen,
yeah.
let's say I've done 3 passes and I'm happy,
Yeah.
but the chip tells you it's not good. What am I going to do differently? The problem is we won't know if this was really insufficient or not.
No.
So if you start out and you have all of that, you know, tissue, whatever in there, and if it's insufficient, just adding one, do you think just adding 1 pass is really gonna make it sufficient?
Working with Kazu, he's very strict and very diligent and very smart. Always trying to do his best for everything. I think Kazu is like Superman. Or like, sometimes I think he's like a robot. You know, he's working 24/7 and he doesn't sleep.
It's my lunch at 8 p.m. What I know I can do well is to work hard. But it comes with, you know, sacrifice and really support from your peers and especially for me, my family, I think. You know, I'm probably the worst person to talk about wellness or work-life balance. So I'm not a role model in that way. I tend to take out my sleep time, and I sleep 4-5 hours, and that's it.
I feel sometimes a kind of pressure, but I think it's very good pressure. This is my first time to living abroad, outside of Japan. But because I understand this, Japanese fellows have difficulty in managing everything, but he always support us. including my family. So I really appreciate that. I would say he's a kind of perfect man, perfectionism. So I'd like to be like that as a doctor and as a research fellow. That's why I came here.
They may think I'm intimidating because they feel that they need to be perfect to work with me. That's not the case, but I think without saying that, I think I might be setting the standard pretty high. I think they probably feel the pressure, maybe with my laser beam eye. I don't know.
What I like the most about this is the fact that there is no answer. In that sense, you are always kind of thinking about it. You're always trying to advance the project and kind of, figure out what to do next.
Andrew, I heard you hurt your back or something?
Yeah. I fell on the weekend and I ended up fracturing the lower lumbar of my spine. Yeah, it was a ladder.
What?
I was up on the extension ladder and slipped and yeah.
What were you doing? Were you doing your ornaments, Christmas thing?
I am a Christmas statistic, yes I am. Yeah.
Oh, jeez.
Yeah.
Well, thank you for joining us. We're gonna discuss about the next step for the Rose HD.
We just got the prototype of the handheld device and we are checking the performance at the bench. This is the one issue. So I'd like to have the opinion from Dr. Shoak. So saline is not working well. So PBST is better for the audio detection.
I'm still wrapping my head around the workflow with the PBST. I'm a little bit concerned. I'm not sure what it would look like if you had cells put in PBST, if I would still recognize them.
So I guess we'll have to test and see if PBST is okay or not.
I think it's the best next step, trying the PBST on some cells from pigs and putting it under the microscope.
So we can collect the lymph nodes from the pigs using the EBUS. Maybe you can help us process this.
Yeah, we can do that. Yeah.
We'll have multiple pigs December and January for sure.
Okay, yeah, we can do that.
2 weeks maybe.
Yeah.
Yeah.
Hello?
Hi, it's Ashton calling from Airsuit. We're wondering if you'll be ready for your pick for 10 o'clock.
Yeah. Thanks. See you in a bit. Bye.
And the third setting is using PBST.
Got it.
Yeah. And finally, we compared this one, and this one.
Got it.
Yeah. Number 3. Oh yeah, can I see?
Sure.
Number 1. What? Almost nothing. Sorry, I need to add 2 patches, I think.
Sure. Do you want us to be 2 and 3?
No, I mean...
You want to redo 1, 2, and 3?
Sorry. Oh, maybe I didn't explain details. So these samples only for number 1.
Okay, sure. My apologies. We did number 2 and 3.
No, sorry. Okay, it's okay. These are same setting. Okay, so for number 1.
Okay, sure.
Every pass is for number 1.
I see.
Okay, sorry.
No worries.
My apology.
All right. Number 1. Number 2. Number 3. And number 4. Okay, awesome.
Or pass.
Yeah, I think it's good.
Okay. Have you done the EBUS TBNA for me?
I really wanted to do.
You want to?
You want to do?
Yeah.
Okay.
Yay.
I'm done. Good.
Thank you.
Okay. And do you want it open?
Perfect.
Yes, please.
Okay, open.
Thank you.
But you're right, that is very different compared to that, right?
The PBS?
No, T.
Yeah, what's the difference? So I'm a bit concerned about this one. So this.
Okay, well, that seems okay there. Here, I guess I don't know.
Yeah, I don't know.
Are you going to blind him?
Actually, blind. Yeah.
Yeah, so you just give him samples.
Yeah,
one to
just
15.
a number 1 to 15. If we get the result from Dr. Stewart before he leaves, so we can, I can start writing the REVs. Yeah. Thank you very much.
Kumi got the PhD in Okayama, and she did again PhD
So she has
here.
2.
She has
So she's a doctor.
doctor, PhD.
Yeah. Oh my god. He's still alive too.
Want to just talk a little bit about what York said?
Yeah, he concluded that we can go ahead with PBSD setting. But that's good news.
Yeah.
That was like make or break for sure.
It's like when you go through those emails, you're looking for that either positive or negative word, right? Like how far into the sentence where it says unfortunately or it says good news, right? That's what you're
Exactly.
looking for. So basically now, if we kind of things that are locked in, or what we would say are locked in, so we know the buffer, like the running buffer is going to be PBST. We know the volume is going to be 1 ml. We just have to be careful on the protocol, right, for that part of like how to handle. And then we know the time, 3 minutes, right?
Yeah, 3 minutes
time.
ideal. Yeah.
So, I mean, to me, I think it's a great way to cap off the 2024 and then swing for the fence 2025.
It's not working. Elevator is up.
This is the prototype diagnostic chip that we are developing. And this is actually the first real-time testing in patients. So, and Scott has been working on this like in the lab. Everyone's so quiet. We're so focused. This is it, Kasa. Okay. You stop or continue? I'm good. Good, okay. Yeah. There's a bit of clot there, so I'm not sure how you're gonna break that, but yeah, it's okay. 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 So looks like 11 huh? Is there anything you can pull? If there's not, you can also sample 2R. There's a high 2R. That one, let's do that. 2R next. Oxygen. Who's color? Who's color? Wait for the reading.
this time machine?
Yes. Yeah, control this.
Go down. It's pretty high.
I will tell you later. There's no feedback.
He's reading it every 1 minute, so he won't tell us until. Okay, all finished. Oh,
Actually, this is a very high number, so good enough.
yeah, good enough. Once he finishes, you gotta take a picture of the first.
Yeah,
This is the first one you've done.
Yeah, with the clinical. Yeah, we've been testing it in other things, but
Yeah, this is the first one. And
Yeah. so he's like,
Right.
see what we're doing. You can see the value go up. And I think, I don't know, well, I kind of know, but
You should
it's
know.
telling me that it's very good adequate sound.
Yeah.
There's a lot of lymphocytes there.
Good, perfect.
Excellent.
Great.
Okay, good.
Okay. Good. Great.
Congratulations.
Very first case.
Yeah.
Top 3 fundraising teams who have raised incredible amounts of money this year.
What I feel is that as a surgeon, there's only so much you can do. There's a limitation in how many surgeries a surgeon can do in their lifetime. And I think that's why I became interested in research. Really, what is a best doctor? I don't know if I'm the best doctor around, but I know I do my best to care for my patient. That I do well, I think. Yeah, I think I'm okay. But maybe I shouldn't say that being, the chief of thoracic surgery at Toronto General Hospital and University of Toronto. We have to be excellent. Maybe I'll get in trouble if I say I'm just okay. I shouldn't say that, right?